What is up? We are here. We are in it. We're doing this thing live again. We are at Spark HQ and we are talking MRIs today. Uh, we're getting questions after the fact, which is fine and great. We'll have a conversation in the morning. If you got your cup of coffee, your orange juice, whatever you got, your tea, you can join us and just ask away. Because every morning we're going to try and do some of this. Get some good info out there and make sure people's questions are answered because that is what we do. So today, we're going to chat MRIs. We discussed yesterday how we see folks all the time come in and they tell me, well, my MRI says everything is fine, or my X-rays are negative, or and then I have pain, right? So there's one end of the spectrum. These are folks who are told that there's really nothing wrong here. Our best weapons to diagnose what is going on tell us nothing is happening. And so anything that you are sensing must be a figment of your imagination. I mean, it must be what goes through the thought process of someone who's seeking help. And of course, that's not helpful. So the other end of the spectrum is, oh, look at all these things on my MRI. Look at all of these little nuggets. Look at all these little shadows. Look at all these little cracks. Look at all these little things. Many times of which are not being interpreted by a lay person or even somebody like myself, but by a radiologist. And of course, they're going to use big words, and that becomes very confusing, or can become confusing. And so, very often, I'll have patients come in and they will give us a CD or something that has information on it and ask us to sort of translate for them. And so, those are the kinds of things we want to unpack for folks here, because just because a word is something you've never seen before, or sounds real bad, like the word tumor, for example, that is medically just very specifically just the word we must use when something on a image has specific characteristics. It doesn't mean that's a cancerous tumor. It just means there's a swelling of some kind. It could be cysts. And see, these are things that people find on MRI. Many times in which they are looking for these kinds of things, but when they're described in impressions and they're described in results of these images, they can use scary language that doesn't make a lot of sense to lay folks. And so unpacking some of that stuff is extremely important. Unfortunately, we have found that many physicians don't spend that time to do so. They assume that the impression will be read by some other practitioner, an orthopedist, a general practitioner, a family medicine person, and the time will be spent to sort of explain this. And that should be what happens. That's certainly what happens here. And I would say, as a general rule, in a lot of physical therapy practices, we do spend more contact time with our patients than many physicians get to. And so we become the default deliverer of some of this education, which is terrific. But even now, what we're seeing across the board is that even physical therapists are being squeezed for time now. So that's one of the reasons why our practice is different. But that's neither here nor there. There are places that you can go, and I highly recommend it all the time, where you seek out folks who are going to be able to spend that time, those valuable minutes that you are there paying for, to get the education on, well, what does my MRI tell me? What in my MRI is actionable? Do I have to do anything about the things that I'm seeing? What about when the pain that I am feeling corresponds with things on MRI? Are there ways to test whether or not that scan is showing exactly what's going on? Of course there are. Are those tests bomb-proof? No, of course not. There is no test, including MRI, that is bomb-proof. So, when things don't make sense, when we see someone move around and their general movement is good, and they're not complaining of a lot of very specific focal recreatable pain, that is tough to tie to imaging. If it's someone who's been around and sought a lot of imagery or a lot of care, it may come to, a practitioner may come to the conclusion that, hey, this person needs to hear some information. And many times, the quick information that docs can impart in the small minutes of time that they get in passing with patients nowadays are things like, oh, well, I don't like this, or, oh, wow, your knees don't look like they're much older. Maybe your knees look like the knees of a 70-year-old, some silliness like that. Or your back is like a 90-year-old spine. And I've heard patients say that their physicians and their close by practitioners that they trust have used words like that, and that's fine. I mean, I guess if you have a rapport, you can use big ugly analogies like that sound very catastrophic. I tend to think that it's hard to build rapport with someone you spend so little time with. And so that's also one of the reasons why I think time with hands-on, time one-on-one is extremely important in delivering not just the education, but like the actual process of this healing thing. So, you're not your MRI. Your MRI is a snapshot in time. It's not under any amount of real load. Usually you're flat on your back. The body operates under loads. Every joint in our body is designed to be good at moving past other joints. And so you're taking a picture of a static system, and usually the pain only happens when we move around. So, we can find areas of big fires, lots of inflammation. We can find areas of very small focal injury when that's what is happening. But the stuff in between, the stuff that happens every day, the muscle related pain, the overuse or poor compensation related pain, that's not something you're going to see on a scan necessarily. You're certainly not going to see things like soft tissue change, that is more of a minute nature, like trigger points, things like that, if you want to get into those details. There are scans that can look at tissue elasticity. And so if that was something that you were concerned about knowing, that would be a scan to get. But I don't recommend those at all. It's just a matter of information. So this was going to be a quick one. I wanted to get this information out there. I wanted to generate some more questions about MRI, about scans, about imaging, about how we utilize that information to mold plans of care. Of course, we don't disregard MRI or X-ray, but it has to jive with the movement presentation. If someone is telling me their doctor told them they need a total knee replacement tomorrow, I would expect that person to have a very hard time walking into the clinic. I mean, almost unable to walk into my space. And I've heard those exact things and those exact words about joints like that, and seen someone walk in with relative ease, even be placed under some load with relative ease. So maybe their scan is real bad, maybe their MRI or their X-ray is just, oh, look at all this bone in here. Everything's just arthritic. Look at your knee; it's got a weird shape. Well, frankly, our standard issue stuff, our bone, our tendon, our muscles, our connective tissues are so much better than anything that we can do to recreate that stuff at this point in modern medicine, that you want to keep standard issue as long as possible. So I'm not saying that knee replacements are not useful. Of course they are. And if you have a lot of pain with your daily activities and your knee is the thing that's getting in the way, that is something that's on the table. But not after exhausting a lot of other options, to include good loading, good patient pain mitigation strategies. How do you manage that stuff? When you have pain, do you freak out, run away, stop, or do you have a plan to address those things? So this is the best way to use some of that data in conjunction with the testing that any good sports rehab person or sports physical therapist will want to do for you if they actually mean well and want to see you achieve the outcomes that you want, and not just check boxes on an insurance form, the way a lot of folks are doing things nowadays. So that's it for today. I got a patient coming down, so we are pumped. See you guys later. Bye.